Welcome to the Reinventing the White Coat podcast, where we delve into conversations aimed at helping you foster a healthy relationship with your career and yourself. If you're a physician feeling unfulfilled or burned out, or want to prevent yourself from going down that path, then this podcast is for you. I'm your host, Jennifer Scher, pediatrician, chief wellness officer, and executive and life coach. Sit back and relax as we explore ways to live your best life and have a career in medicine. Good morning, everybody. I am so happy to be here on another episode of Reinventing the White Coat and have an amazing guest with me who I'm going to introduce in a second, but I just want to first credit both Dr. Drew and myself on our IT expertise this morning, as we both struggled quite a bit getting started today. So I thank everybody for joining us today and spending your precious time with us. And with that said, I'd like to introduce today's guest, who is Dr. Drew Remignanti. And Drew had a 40-year career as an emergency room physician, a 50-year career as a chronic autoimmune disease patient, and sustained a stroke at the age of 38. Now, in retirement, he is a published author of The Healing Connection, a partnership for your health. So who better to speak about the healthcare system, in my mind, than a physician and patient who is now retired and has time to reflect. So Drew, with that, I would really like to truly thank you from my heart for joining me today.
You inviting me on, Jennifer. I appreciate it.
Terrific. So I know your book, Drew, discusses the importance of the doctor-patient relationship and how that's at risk from your perspective in our current health system. And I was hoping you could, before we get into the book, sort of rewind a little bit and tell us about your path, like how you decided to go into medicine and emergency medicine in particular.
I've been asked by people in the past who knew that I was a patient, that as well as a physician, was my experience being a patient, what drove me to decide to study medicine, become a physician. And I usually answer them saying that no, I did not go into medicine because of my illness, but more so despite my illness, because I was in the process of considering going to medical school and becoming a physician when I became chronically ill with my disease, which manifested first as ulcerative colitis. And as someone said to me once during my residency interviews, maybe that wasn't the wisest idea to continue on in your goal to be a physician for your career when you were quite so sick with ulcerative colitis. And it probably wasn't the wisest decision, but I'm a stubborn individual. I wanted to persist with it, so I did.
Stubborn. I like persistent better than stubborn.
Yeah, if you want to put a gloss on it, you could say I'm resilient and persistent. But the fact of the matter, if I'm being honest, I'm just a stubborn. Just to be between you and I'm a stubborn individual, and I hate to. It's hard to dissuade me and discourage me from doing things that I set my mind to do.
Mm-hmm. So
there is no doubt, though, that I chose emergency medicine as a specialty within medicine because I was disappointed and discouraged at how little we could do for certain chronic illnesses in healthcare. My ulcerative colitis was difficult to treat, and so I like the idea that in emergency medicine we see a lot of conditions that present with more clarity about the cause of the condition and more clarity on what the immediate treatment needs to be. So that's what made me choose emergency medicine as a specialty.
Yeah, I do appreciate your honesty about going into a career that requires so much time and energy and work, despite having a chronic illness. I remember when I was in medical school, one of the, as I was rotating through surgery, one of the surgical residents had cystic fibrosis. And I remember thinking to myself, like, God, I wonder if I had that at the time. There wasn't curative treatments. And I remember thinking to myself, I wonder if I would even go down that path. So it's really interesting how we make the choices that we make. So Jude, tell me how some of your experience as a patient informed your doctoring.
It's again, I sort of avoided, not that I didn't want to have a patient physician relationship on the physician end. I saw the value in that right away with how I saw my physicians treating me and the importance of that. But again, the impatient aspect of my personality was that I didn't want to have to, to not be able to bring people to more quicker resolutions of their health problems, and emergency medicine seemed to be more amenable to that.
Mm-hmm. Yeah. And then, so you had ulcerative colitis, and then share with me what happened. How did you go on? You sustained a stroke, you said in your story at such a young age. What was that about, and how did that impact your career?
I think of my chronic illness at the time I developed ulcerative colitis. They were not even aware that it was an autoimmune condition. There was thoughts that it was a psychosomatic condition, which was a little bit difficult to tolerate the implications of, which I didn't believe. And turned out I was right. It was not a psychosomatic condition. It was an autoimmune condition. So the three stages of my chronic illness have been, I basically the entire decade of my 20s, I was ill to one degree or another every single day with symptoms from my ulcerative colitis, cramping, abdominal pain, bloody diarrhea, fever occasionally. So some days better than others. So it was not chronic suffering, but it was never gone. I was in that smaller percentage of patients who never did go into remission with my ulcerative colitis. It was most patients with inflammatory bowel disease have periods of remission and exacerbation. Mine never went into remission. So ultimately, when I reached near the 10-year mark, you are at risk then to developing cancer of the colon from that chronic inflammation. And I was advised by my GI doctor at the time I should consider having a colectomy because of my risk of cancer and also to help resolve my symptoms. So I did. It was a difficult decision, but I chose to go ahead and do that. I had my colon taken out, which, as the surgeons tell you, that cures the ulcerative colitis, which because you can't have colitis if you don't have a colon.
Right.
What doesn't happen is you don't cure the underlying autoimmune process. And
Mm.
so my stroke occurred 10 years later after I'd been, quote, cured of my ulcerative colitis. And the kicker was that they think I developed a coagulopathy as part of that same autoimmune process. And it was at night shift. I was in the emergency department. I woke up having a stroke in my own hospital emergency department. I had clotted off my right middle cerebral artery at its origin. So the complete right middle cerebral artery was occluded. So I had a massive stroke with complete left-sided weakness. And the advantage of having it right-sided is that rather than the left side of the brain, I never was bothered by any of the aphasia, and it did not affect my dominant right side. So there was those bonuses. But unfortunately, about the timing of my disease, that was not the time. What they're doing now is they're going in and they're retrieving those clots. They're basically going in and with a catheter and taking out those clots and restoring flow, and patients are experiencing far less brain damage. That was not available in 1992 when I had my stroke. So I was pretty well knocked down pretty hard with that and was knocked out of emergency medicine practice for a period of 5 years.
Oh, wow. How'd you do
So I,
emotionally?
again, being the stubborn and yeah, it was difficult because you get depression associated with that, not just because of what you're going through, but just the biochemical aspects of all that brain damage results in a depressive illness, which I had that in addition. But again, referring back to the stubborn individual I did not want to stop my career as an emergency physician on somebody else's timing. I decided I was going to try to rehabilitate back into becoming an emergency physician again, because that was part of my identity at that point in time. So that's what I did. It took me a full 5 years, but then I re-entered emergency medicine in full-time practice in 1997. So, and then I thought, well, gee, I got all that patient stuff behind me. I'm just going to be a physician for the rest of my life, and I don't have to worry about being a patient. Now I'm in this third phase of my chronic autoimmune disease in which it's now attacking my liver. So I have a condition called primary sclerosing cholangitis, in which there's chronic inflammation in my liver, which again puts me at risk for cancer of the liver. I'm feeling relatively well with it. It doesn't make me particularly symptomatic, but bottom line is it's made me very sensitive to the role of the experience of being a patient and what the system can do to make us manage our patienthood more successfully.
Yeah.
Was one of the motivations for wanting to write the book.
Yeah. And I imagine there's a lot less compassion around the doctor-patient relationship in the emergency room than there is in the chronic care setting.
It's an ideal circumstance to have a patient-physician relationship. What you do in pediatrics and the family medicine doctors and the general internal medicine doctors, that's really where most medical care should take place, or at least the beginning of all medical care should be. And
Yeah.
unfortunately, we are de-emphasizing and deprioritizing primary care in the United States, and we're putting all of our emphasis and time and money into the specialties, which I resent. And I think it's a bad route that we're taking, which is one of the things that motivated me to write the book, to point out the power that's inherent in a patient-physician relationship, power to convince patients to do what's in their best interest. And I came across a number of fascinating studies showing that patients who have a trusting relationship with their physicians are far more likely to follow through on the advice that they get from their physicians. They're far more likely to become engaged in planning their care, and they're more adherent to their care. And then the kicker is the mortality rate. When you study those patients over time, the mortality rate is cut in half for patients who are more engaged in their health care and more involved and more adherent.
Wow. What do you think behind that?
Well, spoiler alert, I don't come to a complete explanation in the book. What's interesting is one whole set of studies show that they studied, in addition to studying, these were good randomized placebo-controlled studies, and they noticed that patients that were tracking how adherent patients were to the medication regimen, they came across the finding that patients who were more adherent to whatever medicine they were, one study was using statins, another one was using beta blockers. Those patients who were more adherent to taking their medications had half the mortality rate of the patients who were less adherent. So yeah, the skeptic in me said, well, that's no big surprise. All it's proving is that taking good medicines that work, help you to live longer. But the surprising finding was that patients in the placebo arm in all of those studies who were more adherent to taking their placebos also had half the mortality rate. You're saying, well, what's going on there? It remains not completely explained. The two most prominent theories are, one is that there is some basic healing effect to the placebo effect itself. If you believe the medicine that you're taking is going to help you, it literally does. So some aspect of that is, and the other aspect that's been pointed out is what's called healthy adherer effect. That people who are more likely to adhere to their medications are also more likely to adhere to other good medical advice.
Mm-hmm.
So whether it's almost not important which is working. Basically, the bottom line is if you are adherent with the plan that you devise with your doctor, and if you adhere to good medical advice, you're half as likely to die. You know, if it had been 5 or 10%, I would have said, well, that's kind of interesting, but it's not worth writing a book about. But literally, study after study, I came across 8 or 10, and I put 5 or 6 in the book. These are well-run studies showing that we can reduce our mortality rate.
Yeah. So two things that you speak about, the placebo impact and also that relationship. And the first thing that jumps out at me that I want to touch on is the hope that this brings for me that AI won't completely replace um, healthcare, right? I mean, I do think that there's a place where we'll sort of be where there's going to be boop, 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 and a patient will get a diagnosis, or some like pinprick of blood and an entire, whatever is going to be figured out. But there's still going to be a place for that physician healer type person to,
No
to
doubt.
play a role. Is that what your research and feeling
Yes,
about?
definitely. AI is a tool for physicians to use to assist in the patient-physician relationship, and that's all it should be, and that's what it can be, and it should be a great tool if used that way. Unfortunately, the financial decision makers are going to say, gee, why do we even need the physician if AI can come up with some pretty accurate diagnoses and treatment plans on its own? And the problem is if you remove the physician patient interaction and connection, you remove some of the healing power of what happens in the room between a physician and a patient. it sounds kind of soft and squishy, but if you read my book, it's a 300 plus page book with 280 plus references, science-based references sustaining this argument. And I haven't heard anybody come back who's read my book and say, oh, gee, Drew, this doesn't make sense here, or you're really misrepresenting that there.
Well, you're speaking my language because I feel like, when you take like the left brain versus the right brain, and we're very left brain logically focused in healthcare, but I feel like we're shifting towards that more right brain, the need for these more big picture, holistic thinkers. You have data and information at your fingertips. Medical school and trainings should be less data driven and a little bit more holistic driven. Yeah.
There's a, I like I said, a 300-page book laying a fairly sustained, progressive, logical argument for why the patient-physician relationship needs to be resuscitated, not abolished. Business interests are basically trying to declare the patient-physician relationship dead and buried because it's expensive. And they're saying, well, let's use these less expensive options. Let's use providers, non-physician providers, because they're less expensive to pay. Let's use AI because you don't have to pay AI as salary. AI doesn't take a lunch break. AI doesn't take vacation.
Yeah.
So it's basically dollar-driven decision making rather than patient welfare-driven decision making.
Yeah. So what are you hoping to achieve with the book? Who are you trying to reach?
Well, I want to provoke and promote a public discussion that we're having now. Is can we really afford to cut the doctor out of the patient-physician relationship and substitute something short of a fully trained science-based physician in there? And I think patients are unaware of the degree to which business decision-making is what driving what we can do as physicians with our patients. So I'm hoping to promote and provoke a public conversation about it so we can say, hey, we've gotten off track here. We're letting business decisions override patient welfare-driven medical decisions. And I think if enough of us understand that, we can course correct where we're going with healthcare in the U.S.
Yeah. Throughout your career, did you work in different healthcare systems in different places where you saw this approached in different ways?
Well, it was an interesting experience because when I was in residency down in Jacksonville, Florida, they made it clear to us that the term productivity, which is now, you hear that all the time in healthcare, you need to be more productive as a physician, particularly in the emergency department. You need to be more productive. You need to get the patients in and out and get on to the next thing. Well, that's a business concept because doesn't take a business genius to see that the more patients you can see, the more fees you can generate, the more money the system can make. But during my residency, that was never, back in the 80s, that was never mentioned. They did say to us, you need to be efficient, Drew, because if you happen to be in a community hospital emergency department in which you're the only physician on duty at certain times, you need to have your finger on the pulse of the entire department. So you can't be bogged down with this patient for a minor problem when somebody might come in with a more major problem. So you need to be efficient, but productive was never mentioned. But it was something happened between 92 and 97 when I was out of emergency medicine. So I don't remember productivity being mentioned up until 1992. But when I came back into the emergency department in 1997, every single moment they're talking about how productive are we, how many patients per hour can you see? And there is no product in healthcare. There's either information that is good and tailored to you individually and is accurate and important for you to follow, or there's information that's less personalized for you, less accurate, less important to follow. So there's no product. We don't produce anything in emergency medicine or in medicine in general. What we do is we try to convey helpful information and advice to patients to follow and hope that we can get them engaged in their own healthcare.
Yeah. Jude, do you have anywhere as you scan the landscape right now in healthcare, anywhere where you're hopeful?
I think there are patients, there are people like you and I and other physicians. There's a fairly large, I think everyone who works in healthcare understands this problem to some degree or another, that The guiding principle in healthcare should be what is in the patient's best interest. It's not a difficult decision. It's not a difficult question to conceive of or ask each and every moment you're making a decision. What's in the patient's best interest? And I think everyone in healthcare knows that has to be priority number one. And again, people who work in the healthcare setting know that they are constantly at the risk of moral injury, because while they are trying to follow through with that principle number one, they're being told by the people above them, be productive, be more, work faster, work harder, see more patients. And I think that we understand it within healthcare. Patients don't understand it as well as we do, because they come in relatively naive to the inner workings of a healthcare setting. So I'm trying to make patients aware of the limitations of the current system, and trying to basically cause a partnership between patients and physicians. That partnership works immediately for you in your individual healthcare if you can partner and trust with your own primary care doctor. And my hope for the system change is if patients see that physicians are not the problem, we are part of the solution.
Yeah. We have to be part of the solution, and the patients as well, right? But, it is still a business. So we need a financial model that's going to allow whoever's running that business to be successful. If it's not productivity, what do you propose a better way would be?
Yeah, and I quote one of the studies I quote, which is fascinating, is that they did a study, I think it was in 2017, that 1% of the patient population accounted for 22% of healthcare expenditures during that calendar year. Mm. And 5% of the patient population accounted for 50%. And of the remaining 50% of the population, they only accounted for 2.9% of healthcare expenditures. So some of us are getting far more healthcare than we need, far more procedures, far more drugs, and some of us can't even access the system equitably. So I think we can still make a profit in medicine, and people can earn money, and by delivering better care, more effective care, more care that's more appropriate for each person as an individual. They refer to those people as super utilizers, who are in the emergency department 5 or 6 times a month, and they're burning up a lot of dollars in healthcare. Now, if those people had a patient-physician relationship that they trusted and would go to their primary care doctor and avoid emergency department visits, they would reduce the overall expenditure. One of the phrases that's used by the business people is no margin, no mission. Right. By that, they mean if you can't make a profit margin in your healthcare business, you can't carry out the mission of treating the patients. And that's true. You have to be able to turn some degree of profit and pay your people. The problem is that what's occurred now, and we're in a system in which the margin is the mission. It's so easy to make money in healthcare because there's so much money in healthcare that rather than the margin serving the mission, the margin has become the mission.
Yeah.
And I think that's what we need to change.
I've actually not heard that before. And I think the margin is definitely not the mission in pediatrics. So I think that's probably why that's not on my radar. But yes.
Yeah, the pediatricians, the family medicine doctors, the general internal medicine doctors are the lowest paid physicians. And of course, so you're not looking to maximize your margin, you're looking to serve your patient population, which is what we all should be doing.
Yeah, it would be nice.
I came across some really great.
What's that?
I was going to say, people who work in primary care, pediatricians, family medicine doctors, general internal medicine doctors do need to be paid more. We need to incentivize primary care in the U.S. So that more of our healthcare is taken by, more of our healthcare is delivered by people who know us and who we know and trust, because we can therefore avoid a lot of expenses that might otherwise be engendered because I'm ordering a test because I don't know you, because you don't know me, you don't trust me, so I'm more prone to order tests.
Yeah, it's interesting to me to hear somebody who's ER trained to be praising primary care. So
part of it is self-centered, because we see people in the emergency department that I know I'm going to have a hard time helping you because I don't know you. And and in order to make good medical decisions, you need to try to reduce uncertainty as much as you can. And there's uncertainty related to a lot of conditions in healthcare because they produce and present in a way that you're not sure what is going on. But it's easier to reduce the uncertainty if you have a relationship with a patient. And I went into emergency medicine with the idea that there would be less uncertainty there because I'd be seeing more patients that had acute problems that we know what the cause was.
Mm-hmm.
But what happens in emergency medicine is we're doing medical uncertainty at 100 miles per hour with complete strangers. So it's stressful.
Sounds like the definition of chaos. So Drew, let me ask you, as we sort of near the end of our conversation, I'm wondering if you think about yourself today at this stage of your life, if you look back at your younger self, if you would have any advice or tips to give to your younger self.
I wrote my book with medical students, pre-medical students, and medical students in mind, with the idea, what are the kind of things I wish I knew when I was starting my career? And the softer aspects of what helps us to get better, the psychosocial aspects of healthcare, they're not stressed in medical school. At least they weren't stressed in my day. Maybe they are now. Because when you're a medical student, you're trying to learn the biology and the physiology and the pathophysiology of diseases so that you can do right by your patients. And less lip service is paid to making a connection with those patients and understanding the uniqueness of their skill set and their suffering and their ability to cope with their suffering because of psychosocial factors in their life, whether it's anxiety, depression, a broken family, or whatever it might happen to be. So I wish I had known that earlier in my career because I would have, I still would have been just as interested in learning the biochemistry and the pathophysiology of diseases and illness. But I wish I had known the importance of that relationship and the psychosocial aspects of healthcare.
Yeah, that is good. All right. So maybe you can let everybody know where they can find your book.
I do have a website. It's a little bit hard. I don't know if you have the ability to put it on the screen at all, but you can see my name there. Remignanti is not a common spelling, but
yep.
My website is drewremignanti.pubsitepro.com. Just spell my name, no spaces.
So I will put that, Drew, in the show notes so everybody can just click into it.
If you go to that website I created for my book and for my author status, which has excerpts from the book, reviews of the book, and tells you where you can purchase it.
Perfect.
I have a lot of time and money invested in the book. I've been doing this for over a decade now and have some $10,000 out of pocket expenses to make it happen. And so I'd love for people to buy the book. But if you're like me, if I was listening to me now, I'd go to my public library and say, can you get this book in so that I can read it and borrow it and read it? I'm more interested in patients being readers of my book than buyers of my book. Because I think the concepts are important to understand. And again, if you understand them and follow through on them, you can reduce your mortality rate risk by half, which is a pretty good benefit.
Yeah. So you're really speaking to the patients and to the physicians in your book.
I'm trying to get us on the same way. We should be on the same side in this. And I'm trying to get us on speaking a common language about some of the things that make medical diagnosis and treatment difficult.
Perfect. All right, Drew. Any last comments or words of wisdom you'd like to share before we sign off?
I think people who are listening could say, well, you can decide overnight. I listened to this crazy guy, Drew, talking with Jennifer, and maybe I'm going to give that a try. I'm going to go into my doctor's office and I'm going to say, I want to become a more knowledgeable, engaged, and active patient in my own healthcare. You could do that overnight. And even without reading my book, you can see, of course, you'd have to at that point, you have to help your doctor up off the floor and back into their chair because they'll have passed out at the idea that you want to be involved in your healthcare. I think we're beyond ready for this as physicians. We're less ready for it as patients, and some physicians won't be ready for patients playing that active a role. But make that commitment to yourself for your own health. Become more knowledgeable about the conditions you have, become more active in the process of planning a treatment plan with your doctor, and benefit from that. You definitely benefit from it, whether you read my book or not.
Yeah. And let me ask you, since our audience is mostly physicians, how do you think we can encourage our patients to take that active role in when most of them come to us saying, fix me?
Yeah, and this, well, then I've had plenty of people who bought my book and read it and say, gee, I want another copy. I want to give it to my doctor so that when I broach this with my doctor, they'll understand where I'm coming from. I haven't had as many physicians say, well, gee, I'd like to have my patients read that book. But I think, we have to challenge our patients, and as patients, we have to challenge ourselves. So look, this is not something I'm scolding you about, but there are good science studies showing that you will be a healthier individual who lives longer if you become more engaged in your own healthcare. It's asking a lot, especially if you're suffering greatly from your current illness. And it'd be moments when you don't want to become engaged in your healthcare because you're basically sick or you're hospitalized. But patients, if they really want to improve their health, they need to become more engaged, and we need to encourage them in that process.
Yeah.
You have to pick
Well,
the right moment.
I would love a panel of patients that have read your book. I'll end with saying that. So, Drew, as we close, I would like to just thank you so much for joining me today, and I wish you all the success in the world as you sell your book.
Well, thank you very much, Jennifer, for having me on. It's one of the, I thought it was difficult and challenging to do all the research and write the book, which literally took me a 10-year process. But this aspect of it is actually more difficult for me, which is talking about myself in the book. The ironic thing is, one of the points I'm making in my book, I have this end a specific chapter with the following sentence. I said, there's surprisingly substantial evidence to suggest that it is in our own best interest, health-wise, to become less self-interested. So we need to get outside of ourselves and involved with our physicians, involved with our family. And so I find it ironic that here I am spending a lot of time talking about me and my book when I'd rather be out doing something that's more service-oriented.
Yes.
I
Yes.
appreciate you giving me the opportunity to encourage people to read my book.
Yes. Think about it as a service, and then it won't feel so self-serving. All right. Thanks again. And thank you to the audience for spending your precious time with us today. Hope to see you again on the next episode of Reinventing the White Coat.
Thanks so much, Jennifer.
That's all for this episode of Reinventing the White Coat. If you enjoyed this conversation, subscribe now so you don't miss an episode. If you're interested in coaching or in being a guest on the podcast, you can reach out to me online at sharecoaching.com. Thanks for listening, and don't be afraid to live your best life.